We are delighted to have Professor Sesh Sunkara with us. Professor Sesh Sunkara is a subspecialist in reproductive medicine. She's a senior clinical lecturer in King's College in London, in UK. And I believe you will have a very fruitful and very nice presentation. Please, could you make a start, Professor Sesh?
Yeah. Thank you very much, Professor Jibril, and my fellow panelists. It is a great pleasure to join you all from London, and also hello to all my colleagues in Egypt and probably elsewhere. So I was asked to talk about ESHRE ovarian stimulation guidance because that's the focus of this meeting, and I was asked to focus on the high responder. So a little bit of background, which I don't think is new for any of us. We know that IVF results have improved very significantly since the early days of IVF. That is, the first IVF baby was a natural cycle IVF baby, and then stimulation was introduced. And then the success has increased significantly since then. And ovarian stimulation is a vital clinical milestone. It is now one of the cornerstones of IVF treatment, such that 98% of cycles in the UK, US, and perhaps in Egypt as well, use ovarian stimulation routinely. However, interestingly, ovarian stimulation in the context of IVF has not been addressed in any existing evidence-based guideline. That's very surprising. And therefore, to fill the gap, ESHRE has developed the guideline titled Ovarian Stimulation for IVF, ESHRE. For all my colleagues there, you would all be aware that this is available to download freely from the ESHRE website, the entire document, which consists of around 135 odd pages or more. And also the guideline is, the summary of the guideline is published on HR Open and is available freely. So just a background of how the guideline was developed. We followed a 12-step procedure, and you can see the various steps of topic selection, the formation of guideline development, group scoping, key questions, evidence search, evidence synthesis, recommendations. We put out the draft for review for everybody to give questions so that we could, about the draft. And also then we had to get the approval from the executive committee of ESHRE, and then we published it, and then we will continue to revise it as new evidence emerges. So in this guideline, there were 18 key questions. And the way we set out the questions is that it should be very pertinent. They should not be very hi-fi research questions. It should be very pertinent that anybody practicing IVF anywhere in the world should be able, if they have a doubt, they should be able to refer to this guideline and therefore apply it to their practice. And this was the way the questions were set up. So also, I'm just going to give you how we formulated the recommendations and the language we used for the recommendations, so that when you read the guideline, you will understand. So the recommendation was stated as either a strong or conditional recommendation, and this was using the grade approach. You will see what grade is at the bottom of the slide. Also, we used, beside it, the quality of supporting evidence. I will show you when you will see the ESHRE recommendations, you will see round circles, which will tell you whether it is very low quality, moderate quality, or high quality evidence. And we used, by following the above two, we used wording such as recommend or not recommend for strong recommendations. And we use the term probably recommend or probably not recommend for conditional recommendations. So you will see such language as we go through the ESHRE guideline, as you go through the ESHRE guideline. And what are the outcomes we looked at the guideline? We looked at the efficacy outcomes, and the outcomes here start from cumulative live birth, cumulative ongoing pregnancy, clinical pregnancy, number of oocytes or mature oocytes. So we looked for these outcomes. We looked for the top outcome and then the rest of the outcomes. If one was not available, then we relied on the next outcome for the evidence. We also looked at safety aspects, as an ovarian hyperstimulation comes on top. And we also looked for patient-related outcomes in the studies. So we looked at efficacy, safety, and patient-related outcomes when we were formulating the evidence for each of the key questions, each of the 18 key questions. So how we went about the guideline is we followed the same IVF journey that a patient or a clinician would take a patient during treatment. And that is how we went about each question and each point of treatment. So then we had to start off with pre-treatment planning. So that is what we do when we see our patients firstly in our clinics. So pre-treatment planning and ovarian response testing. So what is the question we asked here? The question we asked here is in yellow on the top, which asks, is the assessment of the predicted response to ovarian stimulation sufficiently reliable? Should we be doing this on a routine basis? Is it helpful? And what the answer was, and what we looked at is we looked at ovarian result tests of antral follicle count, anti-mullerian hormone, basal FSH, inhibin B, basal estradiol, and age and BMI. And we looked at them individually. We did not compare one to another. We looked at them each together, each by itself, and saw whether it is useful in predicting response to ovarian stimulation. And this is what we found. AFC and AMH have high accuracy in the prediction of ovarian response. Basal FSH and inhibin B have moderate predictive value. However, for an accurate prediction, very high cutoff levels need to be used. So therefore, they only have a moderate predictive value. Age has some predictive value, and however, assessment of ovarian response by age alone is not sufficiently reliable. Basal estradiol and BMI alone are not predictors of ovarian response. So that was the summary of what we found when we looked at each of the individual aspects, markers of ovarian reserve. So AFC and AMH had high accuracy in the prediction of ovarian response. So with pre-treatment planning, we said for predicting high responders, so in this context, it was high responders and poor response as well, to ovarian stimulation, use of either AFC or AMH, or just mark the wording. We did not say AFC and AMH. We said AFC or AMH is recommended over other ovarian reserve tests. So we said AFC or AMH is useful for predicting high response to ovarian stimulation. And you can see that the evidence is strong here, but the quality of the evidence is very low. The recommendation is strong. So as you can see, the recommendation is strong, but the quality of the evidence is not very high. But as much as we can see, this is the best, these are the best ovarian reserve markers. And this is based on this evidence. If you can see here, AFC for predicting high response, what it shows is that for high response, the ROC, AUC, that is the receiver operator characteristic and area under the curve, is fairly good for prediction of high ovarian response for AFC. Some of them show anything above 8 is good, and you can see 0.81, 0.86, 0.88, and 0.92 for the majority of the studies of high responders and AFC. You have a couple which don't show very high, but overall, it is a good marker predictor of high ovarian response. And here, this is for AMH. Again, you can see the various tests. And again, you see that there are quite a few studies which show that AMH is a good or accurate predictor of high response. So we're going from pre-treatment planning, ovarian reserve testing, and what we are saying is that AFC or AMH are good for predicting high response and therefore planning the treatment for the patient. What about pre-treatment therapies? I'm not going to go through this in detail because it was very much well discussed by Dr. Shafiq in his previous lecture. And as you can see, and as Dr. Shafiq alluded, the various reasons for which we use pre-treatments are listed here. And these are the various assumptions for which clinicians we use pre-treatment before ovarian stimulation. And the question we asked is, does hormone pre-treatment improve the efficacy and safety of ovarian stimulation? Does it improve the efficacy? That is the question. So it is not about programming as we discussed. And you saw this slide before. What it says is that pre-treatment with estrogen before ovarian stimulation using antagonist protocol is probably not recommended for improving efficacy and safety. So if you're thinking that you're using it for improving safety and efficacy, then it is not recommended. The same with progesterone alone. It does not improve efficacy or safety. But as was previously mentioned, we said if you want to use it for scheduling purposes, then you can use it because it's not detrimental. However, the use of combined oral contraceptive pills, as we discussed, is not recommended because of reduced efficacy, and therefore that is important to bear in mind. And we are stressing it, and again, I'm sure we've discussed it quite extensively, and all of you are now clear about this. And this is based mainly on this Cochrane review, which shows that use of COCP pre-treatment resulted in a reduction in live birth or ongoing pregnancy and antagonist cycles. Based on that, we said don't use the OCP. So now let's move to the next step, ovarian stimulation. So the key question we asked is, for predicted high responder, which stimulation protocol is most efficient and safe? So I showed you in the outcomes, we looked at efficacy, which is the efficiency, and safety, and also patient acceptance. And here the question is, which stimulation protocol? So looking at the antagonist versus the agonist, we said that the GnRH antagonist protocol is recommended for PCOS women with regards to improved safety and equal efficacy. So lower risk of ovarian hyperstimulation syndrome, but equal efficacy in terms of pregnancy rates and live birth rates. And that is a strong recommendation, as you can see. When it comes to not all high responders are PCOS patients. So we wanted to give a recommendation just for high responders based on AMH or AFC. There were not any studies. All studies looking at agonist or antagonist were looking at PCOS women in the high response category. They were not looking at non-PCOS high responders. But we said we can extrapolate the evidence from PCOS to high responders, and therefore we gave this as a good practice point, saying that the GnRH antagonist protocol is recommended for high responders with regards to improved efficacy, improved safety, and equal efficacy. So it is exactly the same as PCOS patients. And what is the evidence? The evidence is mainly based, the weight of the evidence is based on the Lambach paper, the Lambach systematic review and meta-analysis published in Human Reproduction Update that was referred to by Professor Mahrabi in his presentation, which showed that comparing the antagonist with the long agonist protocol in PCOS women, there was comparable live birth rates, as you can see, but a significantly lower risk of ovarian hyperstimulation syndrome. And now I think we all are familiar with this, that antagonist is safer. What about mild stimulation? And what is mild stimulation? Is there a role or is there a place for mild stimulation in high responders? First of all, let us try to understand what mild stimulation is. Mild stimulation is a protocol in which the ovaries are stimulated with gonadotrophins and or other pharmacological compounds, could be clomiphene citrate, could be letrozole, could be something else, with the intention of developing a few follicles only. However, the definition of mild stimulation in the studies and what is used in practice is variable. If you looked at research, you will find that one protocol is not necessarily replicated in another study, even by the same authors. What we say conventional doses and what is agreed as a conventional dose is 150 to 225 IU of FSH daily, and mild stimulation is usually uses a lower dose of FSH alone or in combination with other oral stimulating compounds. So mild stimulation for high responders. What about using clomiphene citrate with reduced dose gonadotrophin? We said that the addition of clomiphene citrate to gonadotrophins in stimulation protocols is probably not recommended for predicted high responders. And this is based on the following evidence and justification. There are no RCTs comparing clomiphene citrate alone or as part of an ovarian stimulation protocol in high responders. So there's no RCT as of now. But evidence from cohort studies in PCOS patients has shown that there is no benefit in adding clomiphene citrate or gonadotrophins, either in terms of safety or efficacy. So based on lack of good quality evidence, the GDG, the Guideline Development Group, does not recommend the use of clomiphene citrate in stimulation protocols for predicted high responders. So that's the recommendation with clomiphene citrate. What about aromatase inhibitors? With aromatase inhibitors, the GDG said there is insufficient evidence to recommend the addition of letrozole to gonadotrophins in stimulation protocols for high responders. And again, the evidence and justification is similar to previous in the sense that no RCTs comparing letrozole alone or as letrozole along with gonadotrophins in high responders. Evidence from one retrospective study in PCOS patients showed that there was no benefit in adding letrozole to gonadotrophins in terms of either safety or efficacy. And because of the lack of this any evidence, we recommend that letrozole is not recommended in predicted high responders in stimulation protocols, either alone or in combination with gonadotropin. And also it is important to remember that in most countries, letrozole is off-label used for ovarian stimulation. So now we looked at use of clomiphene citrate, we looked at use of letrozole in mild stimulation protocols. What about reduced dose gonadotrophin for high responders? How much should the dose be and what is reduced gonadotrophin dose? The recommendation is that the GnRH antagonist protocol is recommended for predicted high responders. We've seen that with regards to stimulation protocols, very strong recommendations saying that the antagonist protocol is the preferred protocol for PCOS and high responder women, and none of us will argue here. However, we said this should be used, the antagonist should be used. There is no excuse for using anything else. But however, we said somewhere in some part of the world, there might, the pre-treatment planning might have gone wrong and the GnRH agonist protocol might be used. In these patients, a reduced dose of gonadotrophin is recommended to prevent the risk of ovarian hyperstimulation syndrome. And this is based on the Optimus trial, which most of you would be aware, a randomized controlled trial comparing 100 versus 150 IU of gonadotrophin daily for high responders. And what this study found is in the lower dose of 100, there was a significantly lower OHSS rate. And in this study, as you can see, most of them were in the agonist protocol. So that recommendation of reduced dose gonadotrophin dose only applies to the agonist protocol, not to the antagonist protocol, because antagonist protocol has a threshold for safety. But we should not be using the agonist protocol, as I said. What about modified natural and natural cycle for high responders? What is modified natural cycle? It is defined as a procedure in which one or more oocytes are collected from the ovaries during spontaneous menstrual cycle, and pharmacological compounds are administered with the sole purpose of blocking spontaneous LH surge or inducing final oocyte maturation. What we saw when we looked at or filtered and looked for evidence on this, we found that there is no evidence to justify the use of natural cycle or modified natural cycle for ovarian stimulation in high responders. So no with regards to modified natural cycle or natural cycle. What about adjuvant therapies? This is, I think, a very interesting question and a very pertinent question, is the use of metformin. So we asked, is the addition of adjuvants, in this case metformin, in ovarian stimulation useful in terms of efficacy and safety? And we came up with this recommendation. Routine use of adjuvant metformin before and during ovarian stimulation is not recommended with the antagonist protocol for women with PCOS, and this is a strong recommendation. And what is the evidence behind this? So let us look at this Cochrane review, and this is a Cochrane review comparing metformin versus placebo in women with PCOS undergoing IVF treatment. And what they found in terms of live birth rate is that the live birth rate is comparable. However, what you see is all the studies that were in this particular forest plot are the the agonist cycle and not the antagonist cycle. And we've clearly said, and I think we said there is no argument there that we should be using the antagonist protocol for women with high response of PCOS. So this does not apply if if we are doing the right thing, i.e. using the antagonist protocol, because this is all studies of the agonist protocol in PCOS women. What about OHSS? Because we are looking at two aspects. We're looking at efficacy, but we're looking at safety as well. What about OHSS rate? Overall, if you see that if you pull all the studies, the OHSS rate is significantly reduced with the use of metformin. However, if you divide the studies into those which use the agonist protocol versus the only study which uses the antagonist protocol, with the antagonist protocol, you find no difference in the OHSS rate. So adding metformin to the antagonist protocol did not reduce the risk of OHSS. And then we used another study to back up this evidence, a more recent randomized controlled trial comparing metformin versus placebo in the antagonist cycle. And this study is from the UK. And what they found in this study is that there was no difference in the OHSS rate. As you can see, there was no significant difference in the OHSS rate, whether you used metformin or did not use metformin in an antagonist cycle. But what you can see all across is that the clinical pregnancy rate and the live birth rate decreased significantly with the use of metformin in an antagonist cycle. And therefore, based on this, we made a strong recommendation that because it does not improve the safety with the use of antagonist, and because there is shown that live birth could be lower, we do not recommend using adjuvant metformin in women with PCOS or high responders. So then again, with regards to the monitoring of ovarian stimulation, because this is again commonly asked, how do we monitor our PCOS women? Is just ultrasound enough, or do we need to do any other monitoring tests such as a blood test and FSH, LH, estradiol, progesterone, and the rest? And what we said is that the addition of estradiol measurements to ultrasound monitoring is probably not recommended. And this is based on the evidence of the Cochrane review, which showed that using estradiol in addition to ovarian stimulation, that is ultrasound alone or ultrasound plus estradiol, did not result in improvement in the clinical pregnancy rate, number of oocytes retrieved, or even in the decrease of OHSS rate. This is not just for high responders, but we can extrapolate the evidence to high responders. This is in general, showing that adding estradiol to ultrasound monitoring does not improve outcomes or safety. What about the other hormone panels, such as estradiol, progesterone, LH? Do we need to add all these to ultrasound monitoring? Again, the evidence from the same Cochrane review and additional studies, the evidence from studies showing that there is no improvement in the outcomes, either in terms of pregnancy rates or number of oocytes, if you add all these additional panels to your ultrasound monitoring. So again, we looked at other things. Should we be doing just progesterone on top of ultrasound versus ultrasound alone, or shall we be adding additional LH to ultrasound versus ultrasound alone? So we looked at various things that people or clinicians would do, or have questions whether any of them would have benefit or add benefit by doing other than just ultrasound monitoring alone. But we could not find any evidence that any of them would improve outcomes in terms of either efficacy, i.e. live birth, or safety, i.e. reduction in OHSS. And finally, coming to the agonist triggering of final oocyte maturation. And the question we asked is, GnRH agonist trigger versus HCG trigger in predicted high responders. And what the recommendation is that GnRH agonist trigger is recommended for final oocyte maturation in women at risk of OHSS. Yeah, so agonist versus HCG, agonist is recommended. So the next question is, agonist trigger plus freezol versus agonist HCG trigger plus freezol. So we're putting the various scenarios that we would come across in a clinical situation and answering each question, not just agonist trigger versus HCG trigger, but what should we be doing agonist trigger if we do freezol over HCG trigger, so in various scenarios. And the recommendation is that in patients at risk of OHSS, that is a high responder patients, the use of agonist for final oocyte maturation is probably recommended over HCG in cases where no fresh transfer is performed. So what it is saying is that even in freezol cycles, the agonist trigger is safer than HCG trigger. And we said if you're using triptorelin for your agonist trigger, doses ranging from 0.1 to 0.4 milligrams can be chosen. So they are all of equal efficacy. And continuing with GnRH agonist triggering further, so the other questions are GnRH agonist trigger versus coasting plus HCG trigger. And we said as a good practice point, because there was no evidence there or no studies looking at this question, saying that the GnRH agonist trigger for final oocyte maturation with or without a freeze-all strategy is preferred over coasting strategy in patients at risk of OHSS. So if you have a patient and you were going to do HCG trigger, or you want to decide that you want to coast and then give agonist trigger or coasting plus HCG trigger, which we used to do before the agonist trigger, we said that the agonist trigger is preferable over coasting and HCG trigger. And the next scenario is agonist trigger versus HCG or any other any other procedures or additions that we think will lower the risk of OHSS. And we said that carbogyline or albumin as additional preventive measures for OHSS are not recommended when agonist trigger is used. So what we are saying basically is that the agonist trigger is very safe. So if you have a woman at a high risk of OHSS and you're worried about the woman, go for the agonist trigger. But if you're going for the agonist trigger, you have to get it right from the beginning, i.e. the woman should be on the antagonist protocol. So your pre-treatment planning is very important. And with regards to freeze-all, this is coming to the very end. The question we asked is the freeze-all protocol meaningful in the prevention of ovarian hyperstimulation syndrome, also with regards to efficacy? And we said a freeze-all strategy is recommended to fully eliminate the risk of late onset OHSS. So there's no pregnancy that cycle, therefore freeze-all is recommended to fully eliminate or nearly fully eliminate. Applying the freeze-all strategy obviously implies that whichever center where it is used has a good cryopreservation program with good results for FET cycles. So my colleagues and who are with us in this webinar, I hope you found this useful, and we will open up for questions. Thank you very much.
Thank you very much for an excellent, difficult, and very comprehensive presentation. I would take the chance to thank you in the name of all the board of ESHRE, and they asked me to offer you, if you, just in case you accepted, an honorary membership and honorary boardship. If you accept this, will be our honor.
It is my privilege. You know, it is my privilege. I know that ESHRE members have great authorities. It would be my privilege, and it is, you know, it is a shame that we couldn't have the conference, but I'm very, very, it would be my privilege. And
thank you very much. So you don't do progesterone at time of HCG at all?
You're asking a very, very, a very contested question about progesterone. I think in the next one we should have that as one of the topic. So, do we do protein progesterone testing? How many of I will ask you the question again, or I'll ask my colleagues the question. How many of your patients? What percentage of your patients do have elevated progesterone?
10%.
10%, I think that's a generous estimate. I would ask my other colleague as well. So by doing 10%, okay, so if we find elevated progesterone for 10% of our patients and we do freeze-all for these patients, are we sure that by doing freeze-all that these patients have an improved pregnancy? Are we sure that the progesterone is just affecting the endometrium and it's not affecting the oocyte and the embryo as well? How much of a benefit are we giving to our patients? And by doing progesterone levels and by doing freeze-all, by adding all the additional, how much are we giving benefit? We don't know the answer. Unless you can give, I'm happy if any of our colleagues can come up on that and give their opinion.
Very, very impressive. Tamer?
No, yeah.
Yeah, we do progesterone, and I think it's maybe about 5% of the patients would have high progesterone.
How many percent of the patients? How many percent of your patients?
About 5%, 5 to 6%. Yeah, and we do freeze-all. We believe it could improve.
And you do find it as more than 1.5 or?
Yes, 1.5. Precisely.
Dr. Mona?
maybe in patients with recurrent implantation failure, do you think maybe those would benefit from measuring serum progesterone? We never used to measure serum progesterone. We just tried it this last year. And again, we found similar results, actually, similar pregnancy rates with patients who had high, because some of them insisted on transferring or refused to do freeze all. And we actually find similar pregnancy rates. So maybe just in patients with repeated implantation, it might be beneficial, because these are patients we don't really know what's going on, why it's failing.
Absolutely agree, because we do certain things, and I think with RF we're really tied up and we really don't know we can do it. But I completely agree that, you know, if you actually look, there might not be a difference in the pregnancy rates. The other thing is there are two very interesting studies. One is by Bungum, whereby he looked at the progesterone levels at based on the different times of the day, and what he found is there's a huge variation in the progesterone levels. So if you were to measure it one time during the day, there is a huge variation. So, you know, how accurate is that? And that was replicated by another study that was done at a different center. Nicholas published it, I think, 2 years ago, in oocyte donors. Again, they found that the progesterone levels are up and down. For the same woman, you can have one result at one time and another result at another time.
Yes, I agree. Thank you.
Ahmed, Gabriel.
Thank you very much for this nice presentation. Yes, I think we do have many questions, but for the time, I think this is enough, and we can move to next speaker.
Do you have a question, Gabriel?
No, sir. Okay, that's the answers.
Adil.
Personally, I do not measure serum progesterone at all. It might have a value, is a minute value in my humble opinion, in poor responders. If I just have 2 or 3 embryos and that's it, it might be of help for such patients. But if I have ample number of embryos, I find that it's a waste of time to measure progesterone. I have the 2 chances to have the fresh and to have the frozen embryo transfer cycle. So why abandon one of our chances and stop the fresh cycle? So in normal responders, I never measure progesterone. Might be in older patient and in poor ovarian reserve, I might measure serum progesterone, but I don't advocate it totally empirical for all patients.
So there were a lot of questions again in the audience about also progesterone. Do you routinely use cabergoline or other dopamine agonists in patients with high response or OHSS? Any other adjuvant use, Dr. Sunkara? These are questions.
Yeah, so what we said and what we do is, if we get the pre-treatment planning right, i.e. in terms of, we know that she's a high responder, we start with the antagonist, then we start with a low dose. I mean, we don't go very low, but a low dose in the sense that probably 1125 or 150. And then we go with the agonist trigger. If we are very worried, then we really don't have to use cabergoline and the rest, because what we found, and if we go for freeze all, if you're that worried, we go for the agonist trigger and then freeze all, then we really don't have to use, they don't add any additional benefit. But I don't think you lose anything, but they don't add any additional benefit.
Have you ever triggered with only 0.1 triptorelin? And how mature were the such?
We use buserelin 50 units, and that's what Humaydan uses in his earlier studies, and we found that it's quite good. So we use buserelin, but if you were going to use triptorelin, what they said is you can use what we said is you can use 0.1 to 0.4 milligrams.
For high responders, you start agonist on day 5 or day 6, and any preference, fixed or flexible protocol for high responders?
Yeah. So there is nothing, no study specifically looking at high responders, whether it is fixed or flexible. But in the ovarian stimulation guideline, we did address this question, whether it is fixed or flexible. And we found that you can use either fixed or flexible. So there is no difference with using either fixed or flexible. And day 6 start of antagonist is good enough.
Do you think that there is any evidence, ultrasound evidence of progesterone rise, like echogenic endometrium at time of HCG or whatever?
I really don't look for all of that, so I would not be able to answer that because, with regards to measuring progesterone routinely alone, I'm a bit doubtful. So I don't really look into all that. But as colleagues have said, in very difficult cases, yeah.
Dual trigger or dual trigger or agonist only?
Agonist only is equally good, but in the guideline, or you don't have to do routine dual trigger. In the guideline, we did not address the aspect of dual trigger. With this question, maybe next time when we revise, we will do it. But there are good studies, which mostly from Raul Orvieto, which have come out, which show that dual trigger is quite good actually. So if you have experience with dual trigger, you can use dual trigger. But it depends again how high your risk. If you don't want to give HCG at all, then go for the agonist trigger. But if you get there and you think that your patient is not that at risk, you can give dual trigger. But agonist trigger on its own is good enough.
Well, thank you very much for your presentation, for accepting of our membership and boardship. Thank you very much, Professor Sunkara. Thank you very much.